There we are. Okay. I think we're all set. Everyone, welcome to this is Watch's presentation today on Managed Medicare, a call to arms. This is going to be about a 60-minute webinar. We do invite you to ask questions at the end. If you have questions, you can put them into the questions box or to the chat box, and we'll try to reserve some time at the end to answer your questions. The reason we're having this presentation today is to make sure that you all are aware, which I assume you are, if that's why you came today, that CMS has requested comments on managed Medicare programs or Medicare Advantage organizations. And we want to today just provide you some thoughts, some ideas, some things to refresh your memory about Medicare Advantage organizations and their behavior so that you can formulate a response to their request for information. You can formulate your comments back to CMS. So with me today is Dr. Brian Moore from Atrium Health. Just really excited that he agreed to present today, and he's got a lot of great ideas that he's going to share with us about commenting back to CMS on managed care behaviors. We had advertised that Dr. Kendall Smith from Watch would be with us today. Unfortunately, he's out sick. Brian McGraw, who's the founder of Watch and Appeal Masters, is joining us today in his stead. And then I'm Denise Wilson, and I'm president of the Association for Healthcare Denial and Appeal Management and senior vice president at Watch and Appeal Masters. So today's webinar, as I said, CMS on August 1st had requested that healthcare providers as well as other stakeholders, they've invited beneficiaries to also make comments on Part C Medicare Advantage programs, and the comments have to be submitted to Medicare by August 31st. So we want to encourage that you submit your comments sooner rather than later. Don't wait till the last minute. And also, one thing I want to say is your comments do not have to be formal. They do not have to be in a certain structure. We do have a template that we have created, and it's attached to this webinar. If you go to the handout section of your little control panel, you can download the template and you can download the slides from today's webinar as well. You don't have to use the template. You can go into the Part C CMS request for information screen, and I'll give you the link and I'll show you what that looks like. And you can just type your comments in. There's a lot of different ways that you can submit them. So the most important thing is that you comment, okay? So don't get too hung up. We're going to talk about a lot of regulations, a lot of different communications that have come out from CMS recently, just to kind of bring you up to speed. Don't let that intimidate you. The most important thing is that you comment as soon as you can. Okay, Dr. Brian Moore is Chief Medical Officer, Physician Advisor Services at Atrium Health. He's a national leader and advocate on Medicare and Medicaid Advantage, Medicare, and I think that's what I'll say, Medicaid Advantage issues that directly affect patient quality of care and unfair denials of patients' necessary level of care. Dr. Moore is board certified in emergency medicine and a member of the American College of Physician Advisors. Brian McGraw is the founder of Watch and Appeal Masters, each firm being a national leader in appeal support services and next generation denial and appeal management software. He's a nationally recognized speaker and sought after expert in areas of revenue risk management, regulatory audit management, and payer compliance. And he's very passionate about this topic. I'm sure that will come through when he speaks today. And me, I'm Senior Vice President at Watch Appeal Masters and President for Association of Healthcare Denial and Appeal Management, which if you're not a member yet, you should be. Check us out at www.ahdam.org. I've been in healthcare my entire adult career, and I've been in denial and appeal management for the past 17 years, and I do a lot of education on managing denials and appeals. Okay, so let's get to the meat of what we want to talk about today. I want to just do a little bit of a background so that you are kind of up to speed on where we are. So there's been a lot happening with CMS, especially in regards to managed Medicare this year since 2022, since the beginning of 2022. So let's go over a little bit of that before we dive into what Dr. Moore and Dr. and Mr. McGraw have to say today. So I invite our two Brians to jump in if there's something you want to also add to this little background. So I'm going to go back to April of 2022, and there's an OIG report that came out that talked about, they did an audit for for Medicare Advantage organizations, and what they determined from that report, and I encourage you to go out and read it if you're not familiar with it, is that MAOs used clinical criteria that went beyond Medicare coverage rules. For example, they looked at before approving an MRI, they might say, well, you need to have an X-ray first. When traditional Medicare does not say in an NCD or an LCD or anywhere in their policies that you have to have an X-ray before you have an MRI. So that was one of the things that the OIG found in this report. And one of the things that I thought was really interesting is the OIG said that CMS guidance is not sufficiently detailed to determine whether MAOs can deny authorization for their service based on their internal clinical criteria that goes beyond Medicare coverage rules. So that certainly is a concern and something that I think, CMS has agreed with, and from this report and has agreed to look into that going forward. Now, they only looked at a few inpatient claims, and they really didn't look at them based on, because I know you're all wondering about the 2-midnight rule. They didn't really look at that. They looked more at outpatient services, DME, physician services, and those types of things. But it's good to go through and read this report and get a sense of what the OIG found and how CMS is responding to that.
And Denise, I'll just comment on that.
Sure.
In the appendix of the OIG report, it did list one of the denials as being an inpatient denial that they felt was appropriately covered under the 2-midnight rule that was denied. And so it didn't call it out specifically, but if you look at the appendix, they have a few summaries of cases at the end of the OIG report reflecting the cases that they looked at. And one of them, it might even be two of them, were actually inpatient denials that they felt were generally would have been covered by Medicare.
Right. I agree with you. I think, and I don't think they specifically came out and said 2 midnights, but they did say inpatient should have been covered under Medicare guidelines that would have been covered, traditional Medicare. So, yeah. So good to read through that and make sure you read through that appendix. And then I believe it was in, I don't remember, it might have been in May of this year, but it's not important. Anyway, this appeals decision search tool database came out on the CMS website. This is where the QIC, which is the independent review entity for managed care for non-par cases, non-participating, non-contracted, when there's a denial upheld from the managed care organization, you appeal that, and then if it's upheld, it goes automatically, gets advanced automatically to an independent review entity if you're not contracted. Or if a patient initiates an appeal, their appeal also goes to the IRE, which is also called the QUIC. If you go to this database, and I've got the URL there, you can search, and you can put in words to search for different types of decisions that they've made. You can see that when the QUIC made decisions based on level of care for level of care decisions, that they were rendering those decisions using traditional Medicare 2-midnight rule. So I think that's helpful to kind of understand that that is what Medicare is looking for managed care plans when you're not contracted. One thing they didn't tell us in this database is whether the cases that are represented there are from non-par appeals or from patient-initiated appeals. So that's not really clear, but as you read through them, you can kind of make out which ones might have been patient-initiated and which are not contracted. Okay, and then just in August, the beginning of August, CMS issued an update to Part C and D enrollee grievances. So there's this whole 117-page document out there that talks about Part C and D grievances, determinations, and appeals guidance. They combined C and D together a few years ago into one document, which makes it, in my opinion, kind of difficult to read. I know there's a lot of crossover between Part C and Part D, but I don't think they did us any favors by combining them. So you just have to be careful as you're reading through and make sure that you are looking at things that apply to Part C only. So some of the things that they kind of bolstered or made a little bit more clear to MA plans as well as to providers, and Dr. Moore is going to expand on this a little bit, is under 50.1.1, they said a non-contracted provider who is enrollee signee must be afforded full administrative appeal rights in accordance with 42 CFR Part 422 Subpart M. So they're making that a little bit stronger stance on making sure that non-contracted providers who are enrollees assignees have full administrative rights. Another thing was if the service or benefit was received prior to a notice of decision. So if the enrollee requested a pre-service consideration and the MA plan is kind of, dragging its feet and making a decision on that, and it turns out by the time they make their decision or the time they're ready to make their decision, they find out that that service was already completed, they can't just dismiss it. They do have to go ahead and review that as a reconsideration.
So this is Brian McGraw. So one of the points I would make these two prior slides is you see the word patient and you see the word enrollee. And I think we've been talking for years about the opportunity to appeal on the patient's behalf and making that part of your process. I'm pretty sure you're going to see patients who are making comments to Medicare, and I would invite all the attendees, if you're a patient who's had a horror story with one of these Advantage plans, it doesn't hurt to try to reach out to them. But the fact is that enrollees' rights and patients' rights are really important, not only to the provider, but certainly to the fair shake for the patient.
For sure. Also, just want to talk about a little bit about you do not have to have a non-contracted provider does not need to receive a zero payment to request a reconsideration. Okay, so if you get a CV, and what I mean by that, clinical validation denial that decreases your payment, if they're downcoding your claim, bundling issues, rate of payment denials, they've expanded on that a little bit in this guidance to say it doesn't have to be a zero payment. You still have access to go to the appeals process for coverage that's not paid. It's a partial pay for that coverage. And again, I think Dr. Moore is going to touch on that a little bit as well. And then prior authorization and management requirements. I thought this was really something I was really happy to see here, and I'm sure all of our physician advisors and anyone involved in peer-to-peers will be very interested in this one, that they've basically come out and said that the peer-to-peer discussions are not to be used by the MA plans to solicit a substantive modification to the request. So they're not to use peer-to-peer discussions to try to get the physician on the provider side to agree to a lower level of care. The MA plans may not interfere with an enrollee's right to receive a requested initial determination or obstruct the enrollee's access to the appeal process by any means.
And Denise, if I could comment further on this, I think this is going to be most important here. If you go back to that language, I'm sorry, in your post-acute placement, or pre-authorizations. The inpatient determination for observation, we obviously know when we're doing peer-to-peers that the medical directors will try to talk us into a 7-day stay as being, appropriate for observation. And frankly, we know with, unless you have physician advisors doing this, which I'll touch on later, physicians might just think you make the rules. So, okay, I'll change it. I don't think that's going to still be processed by the plan as a denial and an uphold, and that's following this process. They shouldn't be using it or saying that it should be, but nonetheless, they're still going to process that as a inpatient, pre-auth request that was denied, and that'll still be tracked and reported to CMS as such. And then if you submit the claim as a outpatient observation claim, it's going to process through their claim edits and it won't bounce. I think where this is really going to impact is that when you have a post-acute peer-to-peer and you're, for instance, having a post-acute discussion about inpatient rehab, what the medical directors will occasionally do is say, well, I know this 3-discipline stroke, you feel it should go to rehab. It doesn't meet our criteria for acute rehab, but we will approve a SNF. And if you agree to that on the phone, a lot of them have been processing that as a verbal withdrawal. And what that means is that looks like instead of the denial occurring and it being processed and logged and included in their data to CMS, it's logged as a verbal withdrawal of the initial auth request for rehab, and then it's looked at as an approval for SNF, and that data then skews it, and that looks, in that way, that's CMS will be blind to that activity, except for the plans are required to document, the verbal withdrawal. But we all know that's really not a verbal withdrawal. It's a lot of doctors who don't understand that they have to cover what Medicare does, just giving in and saying, well, Plan X must not cover this rehab for the stroke, so we're going to just go for the SNF so it doesn't take 6 days to get them out because we don't think they're going to cover it anyway. And then that looks like it's actually a positive thing, that it was a withdrawal from an inappropriate request that gets withdrawn by the provider, and then a SNF request it's approved, and it doesn't look like it's actually a patient denial and the patient won't get their rights in a letter. And so I think this is really going to impact. And providers need to be aware of this to make sure that whoever is doing these peer-to-peers, often it's the attendings, that if they really don't think, they need to know if they think it's covered by Medicare, they should be pursuing appeals and educating their patients as such. But this is a significant change.
Okay, Dr. Moore, you want to continue on with your thoughts on the additional Part C?
Yes, and this is pretty significant. Medicare became aware and was aware in 2020. They issued guidance to the plans that essentially non-contract providers who, especially if you've received payment, that's supposed to be that if you receive payment for a service that was provided, that is considered a organizational termination that was positive. You received payment. They didn't need to give you notice. They just paid you. And any revision of that is supposed to be considered a adverse determination or a reversal of that positive organizational determination with full appeal rights. And what you mean by full appeal rights are the 5-level appeal options. And so where this is going to really impact, because they announced or sent a notice to Medicare Advantage plans to say, if you're doing this, then these need to, providers, non-contract providers need to be given full appeal rights, including the escalation of the IRE. What they did in August 3rd of 22, and it's in the Part C and D grievance update. It's in red. I left it in red because when you scan through the documents, the red are the new changes. It's what they've clarified, and this is clearly from feedback from the provider community. But what they went to list the examples, and anybody who's non-par or even par, basically what this includes are like clinical validation denials and other areas where you get from an auditor, a post-payment downgrade of payment. That is a negative or an adverse organizational termination. You have full appeal rights if that happened. As you know, you won't get that outlined in that denial letter. What you'll get is, if you agree, check yes, send this in, and we're good. It doesn't even explain your appeal rights. And so, and what people who have been caught up in this process, non-contracted and contracted at times, you will often appeal it and then it'll come back with thank you for the appeal. Doesn't really look like anybody read it. Still says, sorry, we disagree with you. If you agree, refund our money. We take no action. We'll just take our money back. If you don't, submit another appeal. And honestly, that can go on to 4 or 5 times. What they are supposed to do for the areas listed below is if you appeal once, if you send in a no, we do not agree with it. So if you agree with it, just recognize it means you agree with it. It means we think we got this wrong. In these areas, if you're getting this, it doesn't matter if it's from a third-party auditor, if you got paid or if it's even prepayment, and if you had an authorization for an inpatient stay, and then they deny it, you are able, as a non-contractor provider, when you appeal this, it should go first to the plan, which is the reconsideration, and then if that is upheld, you should do nothing. This should automatically go to the independent review, and then you should have ALJ rights after that. And so if you are stuck in this auditor, circle of nonsense, it doesn't make sense to anybody. Recognize that CMS has specifically called it out, and they gave examples. This is fantastic. So read this, please, because it's very clear. But it says, if a plan later reopens and revises a favorable organizational termination, which is the payment, so if they're taking any money back, and denies the DRG code on the basis should be a different, then that is subject to full appeal rights, meaning you send in one appeal, one good appeal, and they could not read it if they want, but guess what? That should go to the IRE. And then if the IRE upholds it, it should go to you should be able to have ALJ. So there is now really robust language in here, down coding. And again, this is, if a plan looks at a favorable determination that they decided to approve inpatient services, and then you get a letter from a nurse as part of an audit team 6 months later that said, gee, we approved this before, but now we're saying this should have been paid as this 7-day stay should have been paid as an outpatient. You used to write one letter and then go through the repeat, wash, rinse, rinse and repeat without people reading your letters. It feels like now we know this should go to the IRE. So it's down coding, it's DRG payment denials, it's bundling, it's level of care, so it's inpatient obs. If you are non-contracted, this is something I would consider, and we'll talk about kind of solutions down there. But if you're non-contracted, realize that CMS has a non-interference clause. If you're contracted and these decisions happen, you're supposed to have a contract that is your business decision, and that you really are supposed to resolve those disputes inside that contract before you without escalation to CMS. They're not allowed to intervene often. However, if you're not contracted, there's none of that restriction, and CMS is responsible for overseeing that goes forward. So you're supposed to escalate these if the process isn't followed. So I left all the language in here. We don't need to read each one, but just if you're getting a barrage of auditors, and you're non-contracted, this should really clearly delineate you've got rights, and you should be looking to escalate those. We'll cover that in more detail.
Okay, one more slide on the background, and then or 2 more slides maybe on background. This is just the URL to go to that Part C and D and Rule A grievances, organization determinations. And then also, we talked about a lot of this on the American College of Physician Advisors town hall meeting last week. And I don't know when that recording will be posted, but Nina Youngstrom from Report on Medicare Compliance wrote up a nice summary of some of the topics that we talked about. So I have the short URL there if you want to read that. That will kind of help clarify some of the things that we're talking about today as well. And then to get to the topic at hand today, the request for information from CMS that came out August 1st, 2022, seeking feedback. The 2 areas that I'm going to point you to, they asked for, there's 5 different areas that are asking for feedback on. Some of it has to do with, value-based care and those types of things. So certainly if that speaks to you or something that you have issues with, you can speak about that in your comments. But for today's purposes, because we're here to talk really about denials and appeals and utilization management, these are the 2 areas within the CMS request for information that I would point you to is called B10 and B11 under coverage and care. And that's utilization management feedback that they're asking for. And then I've also got the link here for you to go I'm going to walk you through how to submit your comments at the end of the presentation today, towards the end. But this is the URL, and those are the two areas that I recommend that we comment on when it comes to denials and appeals. Okay, I'm going to let Dr. Moore continue with his observations and comments.
Sure. So there's three areas that we're just going to break this into, and then just have some solutions that you can potentially implement, and just recognize that these are areas that we all are seeing if you're contracted, non-contracted. But it's the inpatient, outpatient, short stay inpatients are not what we're talking about. The denials that we're seeing, the very, aggressive denials between for authorizations. Remember the difference between claims and authorizations. When you're getting an authorization, all you're doing is getting approval. You're required to get that with most of the plans. You submit it. It is not a claim, denial. It's an authorization denial. And if you overturn that authorization denial, then in their claim system, they will have it ready when an inpatient bill type hits that it'll pay. And so if you don't overturn it and you submit, you say you miss a peer-to-peer window, or you have attendings doing this and a lot of them don't get done because the windows are often tight. Peer-to-peer is not required in any of the regulations. However, some of the certification bodies do require companies offer it. However, it's not required in the regulations, so it's a way to exchange information. And we have found it to be much more effective, and I think most physician providers found it to be much more effective to overturn inpatient auth denials than claim denials when you write appeals. Obviously, there's always going to be need for appeals, but if you can overturn the majority of these on phone calls, it's the best way to do it. However, these are not overnight stays. These are not overnight gallbladders, abdominal pain that resolves in 2 days. These are generally, 4 to 7 day stays on average. And it's a very high volume of cases, frankly. It feels like, and I think most of us would agree, and this is the type of information we should be consistently inputting to CMS when they're asking, look at what your average peer-to-peer case is that you've overturned or upheld and had to appeal. See what the length of stay is on that. Everybody confuses this with short stay audits like the QIO, what they've done. Our observation window we're looking at is not short stay. It's usually 4 to 7 days. Often these people go on and get much sicker than the initial auth denial that you couldn't overturn because on day 3 they didn't have so much IV fluids going or whatever criteria they used. They can even go on and get intubated and they don't get overturned after that auth, the peer-to-peer is completed. And so let people know this is, not short stays. And also recognize, that every plan, if you went and looked at you can't find their Milliman or their interqual criteria on their websites. They can reference third-party national coverage criteria. However, they're required to use Medicare coverage criteria when they define inpatient, they define observation. And that is the policies that you should be discussing. Obviously with peer-to-peers, they're not going to be bound. They should be bound by this, but you're not going to be able to hold them accountable for it because it's a he said, she said, whatever happened on that call. So you're trying to get them to overturn and just get the auth overturned. But when you do actual appeals, you really should be using Medicare coverage criteria as your basis. And you can also say if it met clinical coverage criteria in addition to that. I think the nuance the OIG pointed out about them being more, they can't be more restrictive. However, there's this concept that they could be more specific. And I think what we're seeing is definitely more restrictive, but that is clear definition. I think that CMS is going to hopefully have to clarify, is a 7-day medically necessary observation case actually more restrictive? Seems logically it is, but logic doesn't always apply. So recognize every time that somebody on a peer-to-peer, if you agree to it, if you change people to OBS, or if you end up not appealing a inpatient claim denial just because you think that you have a low chance of winning, it means you agree with it. Essentially it looks like you agree with it, and it's something that unfortunately it's going to be successful on their part, and they're going to continue. So we need to collectively just voice what we think is really Medicare coverage criteria on these cases. That's what we should be holding them accountable to. So I would just say, make sure for your solutions on this, you understand the difference between authorization and claim denials. It's very powerful to build your physician advisor program on this alone. you have to manage your inpatient, outpatient, appropriately advancing people, especially for all the government payers that we're required to do that for. But being able to intervene on the authorization denials that come from these peer-to-peers and on behalf of providers, you can probably get over 90% resolution of the dispute pre-claim, which means that you can adjust the bill before the claim goes out if you agree it should have been observation, or if you're not going to appeal it, or you can get the authorization overturned. And if it does, it actually pays much quicker than it would if you didn't do anything about that peer-to-peer, because it would automatically deny. It could be a 30-day case. If it denied on day 2, you're going to submit that claim for that 30-day case. It's automatically going to go to an appeals pathway, and you're not going to get that revenue for 6 to 12 months, depending on how fast you write your appeals, or if at all. And they have much lower overturn rates depending on the quality of the appeal. Obviously, the higher the quality, the better the overturn rate. So I think physician advisors need to build their peer-to-peer program and profile it accordingly, because it's a very effective intervention, and it really helps to protect the revenue of your hospital. If you're contracted, you really need to look into your contracts. This is an area that's a blind spot for most physician advisors. It's a blind spot for often a lot of the revenue cycle team that you're working with. Obviously, rates and other things like that need to be protected. However, and there are legitimate anti-competitive concerns with, who has access to contracts. However, recognize that if you're in charge of managing a vendor relationship in any business, if you don't know the terms of your contract and people are doing things, they won't know the terms of your contract. I almost guarantee you the upfront people you're dealing with on the plan side have no idea what your contract is versus anybody else's. They have their processes, their procedures. And if your contract is something more specific, you need to be able to call it out, know it, use it in your appeals, and then dispute if you don't agree with a plan. For instance, if they're combining readmissions for 30 days, if that's not in your contract, or if it's in your contract, they can't, you need to know that. That's the first question people should be asking and escalating. So know your contracts, make it clear. You're not looking to cancel contracts. You're not looking to threaten. You're looking to understand the rules of the road, so that if it's a business decision that was made, you're going to, if it's in your contract, you allow 30-day readmissions to be determined by the plan to be combined. Guess what? You don't have a leg to stand on. That's what you guys agreed as a business decision. So you want to know that before you are appealing, and you want to also help to inform then obviously better contractual terms to be able to make more sense in the space. But you really have to pursue it and partner with the folks that are the contracting. So non-contracted, as we went over, you have access to full CMS appeal rights, and you just should recognize their significant, I think, power and comfort if you know that. And then when the plan doesn't do it, figure out ways to escalate it either to Maximus, that they should have sent the case to them, or to the CMS reps. And if you're not getting access to these, I would absolutely make comments to CMS on those that are not getting access to these appeal rights, because they take this serious. They're not going to get in the way of the contractual business relationship. If you're not contracted and you're having this runaround, and you're seeing that, you should absolutely be commenting on it to CMS. And then again, the pre-service and dismissal is really interesting in the Part C and D update that they just did in August of 2022. We're really looking into this, but this might allow the ability to use expedited authorization appeals for inpatient denials, whether you're contracted or not, and being able to get that forwarded to the IRE for a level set, right? That's the whole issue, is we don't have ways to have a level set, to have somebody who's not involved with the plan processes to look and say, you're actually not allowed to do this. The IRE is really the way to do that. It's worked well in the post-acute space, but this is something we're hoping is gonna, CMS has made this more available, even if it's as a claim dispute. So we'll see. Next slide. The next that we're seeing is obviously post-acute authorization processes and delays. This is just requires high advocacy. We know that people and physicians, providers and physicians, families that, patients that are likely, are at risk, the elderly, don't have many families to support them, maybe not high education levels. This is a very complex issue, and frankly, the more barriers that are put up, the more likely people are to abandon it. So the longer it takes, and the more aggressive the denials, knowing that they can potentially overturn it at the plan level before it goes into CMS's vision, recognize that we need to be better advocates for our patients, and also I think help the providers understand appeal pathways. But there is really good regulations that, if they're followed, and we can leverage to use. And so we are seeing across the country, hopefully facilities can measure this, but try to measure against traditional Medicare, or you can just measure your MA plan's length of stay. But we've done it against Medicare, and what I'm hearing across the country is people are quoting 2 to 4 days. Some are even quoting 4 to 8 days. Recently, even the difference between navigating MA plans, getting people out for the same exact diagnoses versus traditional Medicare. And so this is something that we need to give feedback to CMS on. If you're experiencing this, if this is causing delays, or people are just sitting in your hospital waiting, this is not a good patient treatment, and plans should be aligned with us on getting people out of the day that they're medically ready. And somehow, if there's an authorization process, it should coincide with the care process to be able to get people out the same way the care process does. So solutions, again, know your rights to expedited appeals, understand the power of the IRE. So plans can tell you anything on the phone. You call and you try to do this. If you get a fax, they're all required to have a fax. You can get a one-page fax, automate it. Automate your authorization and appeals similar to the plans. You can use their portals, but often they force you into much more information than you need. You can always use fax templates. I think that's a very easy way that you can do this, and really leverage the power of expedited appeals and physicians. If physicians say something should be expedited, and if office staff working on behalf of physicians say something should be expedited, that means a 72-hour turnaround at longest, and the plans cannot dismiss those for an appeal or an initial determination. And one of the areas for your contract is, some contracts go back to the even pre-2000 times, depending on the contract that you have, and they get addendums and addendums. Look in there for administrative day, or ask people if you have administrative day payments in your contract, your contracting folks, because you might get significant payment for each day. They might have different language. Some are beyond a length of stay. Some are for waiting for placement, other things like that. But whatever the language is, if you have it, it's a missed layup if you're not going and executing on it. A lot of contracts have this, not a lot. If you find contracts that have it, I would say a lot probably are not executed. And so just recognize this is a way that you can get a plan aligned with you. If they're not willing to align with you on the concept of getting people out earlier, they might align with you on not having a significant financial outlay if their delays occur. And then, like we said, register your complaints and your experiences. And we have to get better collectively at telling our stories. I think use good patient examples that are reflective of what you experience regularly. I think the really bizarre one, I wouldn't use. I would use ones that you see regularly and really tell a story when you submit your information. Next. And the last is the contract process we talked about. Again, there's in 2020 they updated this and it was a reminder. So it was not a new guidance. It was a reminder in 2020 that they were supposed to be doing this. So they were always supposed to be doing this, but there's more and more clarification and more specificity coming out from CMS, which means they're listening. This August 3rd update, I encourage everybody to go read it. It tells you what your rights are, and it's confusing at first. And honestly, you have to read it a few times. But if you're in this space, there's the tactics of trying to do all these, and then there's a strategy of figuring out what am I doing? You need to get and understand the rules. That's the only way you're going to put together a strategy that can inform your tactics, because there's a short and long-term play on all of this. And it's really just to get people the appropriate level of care in the appropriate setting, appropriate timing. We are not looking to overutilize anything. We want to be partners, ideally, but we need to recognize there are actual rules, and this non-contract processes, I think, is if you are not contracted, you need to go and read this. I would cut and paste this and submit this to whoever you can inside the plan, or whoever's denying you, to let them know they're taking away your rights, and CMS will take that seriously.
Agree. It's good to hear that CMS, we get the feeling that the needle is actually moving a little bit, that they're starting to listen. Dr. Moore and I will talk a little bit, or Dr. Moore, if you have anything you want to add to this, a little bit about the egregious use of guidelines to substitute for physician judgment and treatment decisions. So, in theory, we believe that MA plans whether you're contracted or not contracted, should be using the Two-Midnight Rule, particularly if you're not contracted. If you're contracted and you agree that you're going to abide by their use of interqual or milliman, then that's a different situation. But in the way that the CMS's, the CFR and CMS's guidance especially for non-contracted, definitely need to follow AMA plans. And one of the things that kind of concerned me a little bit was, they were supposed to comply with NCDs and LCDs, and then the OIG report saying that they were actually being more restrictive than what's in LCDs and NCDs is a little bit concerning. So, if they're using, go ahead.
I'm sorry.
Go ahead, Brian.
I think, one of the things that's important to comment on is, when I first started in 2014, my whole life was learning the Two-Midnight Rule, trying to wind down all the rack, and it was a mess, right? Our relationship with Medicare, it was a mess. This whole short stay inpatient thing didn't meet the intensity, the risk. It was a mess. I don't know. I honestly think the Two-Midnight Rule is fantastic. I think it's pretty clear. It helps, and when I talk about adjudicate, I use that word on the other, other forums as well, but it's how people make decisions. And when you disagree with it, if there's a question that CMS is or the OIG is having because the rules for CMS are not clear, if something is more restrictive or not, we had that problem with CMS on this exact issue. And the Two-Midnight Rule helped make it a lot clearer, unless you had a case-by-case exception or, some of the exceptions to the shorter than Two-Midnight Rule, then generally it shouldn't be paid as an inpatient. I think it's helped to really get rid of a lot of our friction and conflict in this area. And frankly, it's hard to compare how Medicare Advantage is going to do versus Medicare if they're taking a bunch of MIs that are 5-6 day stays and people are agreeing to treat them as outpatients. It's going to be hard to have quality comparisons. It's hard to compare utilization. I call it kind of payer innovation in this area. The Two-Midnight, letting CMS know if you think the Two-Midnight Rule has actually helped our ability to define and tell providers, this is a medical decision. Do you expect 2 midnights of hospital-only level care, not including delays, not including convenience, not including I'm blanking on the last, but just a custodial. If you like it, tell them that this is what you think we should use for it all. It would get rid of all this criteria issue that we're dealing with. If somebody has 175 cc's going on day 3 or not of IV fluid, that shouldn't determine if you're an inpatient. That level of the use of clinical criteria. So just be sure to talk to CMS on this if you think this is a good level set, because I think this would be one of our solutions that they could.
Right, and you can view the comments that have already been submitted to CMS on this, and if you just type in Two-Midnight or inpatient, you'll see that people are commenting on that over and over and over again. Okay, Brian McGraw, you're up. He's going to give us tip number 5.
Sure. Well, I've been talking about this for years, and that is that we think one of the Achilles heels of these plans, especially the plans with behavior problems, is their adherence to NCQA and URAC. And so the very fact that whether it's a plan or a commercial plan, they really want that accreditation. And that accreditation buys them into certain state Medicaid programs, and certainly buys them in as a contractor to CMS for MA plans, as well as these RAC contractors. So they all have to be certified by either NCQA or URAC to participate in these programs. The thing is, they're supposed to be holding these private plans accountable. And it's difficult for us as providers and provider advocates to really understand what are the and quality management rules that are in these particular programs. Well, a lot of hospitals have started ACOs. A lot of health systems have started their own health plans. And so getting access to what these standards are isn't simply a matter of making a phone call or going onto their website. So these standards are very, very important, and that accreditation is crucially important to the plan's success in penetrating different states in different marketplaces. So we've recognized, and I've been recognizing for years and years and years, that they are in violation of these standards. And some of the standards are as simple as how long they have to respond to an inpatient appeal. And so back in, I want to say the early parts of the century, I'm not going to go back too much further than that, the standard was 30 days. If you didn't have a decision, a response within 30 days, you were able to report them and actually go on to the NCQA or URAC website and threaten to expose that. So gathering those violations of the URAC standards, whether it's related to the utilization management program, whether it's related to the appeals process. Dr. Moore mentioned something earlier about the descriptions really not being included on the letters. Well, it's actually in the NCQA and URAC standards that appeal process has to be specifically outlined, that grievance process, for them to be an accredited plan. And so when you realize that either the auditors or certain payers are not including what's the appeal process, not only for the hospital, but what's the appeal process for the patient. I think a lot of folks will notice that when you get a denial letter, it's not addressed to the provider, it's addressed to the patient. And so recognizing that if there's strong procedural rules that are written out in that particular letter, but if there's no rules and no definition of what the appeal process is, that's a violation of these two accreditation agency standards. And to us, if you don't know what those standards are, you really can't call them on it. So it's up to the providers themselves, up to the hospital and health systems themselves to reach out to URAC and NCQA and begin to understand what are their accreditation standards. No different than we have to go through JCO accreditation every couple of years or other types of accreditation. We have to be held to EMTALA rules. We think that we should make sure we know what their rules are to be an accredited plan to serve this marginalized and elderly population. So if you don't know what URAC and NCQA are today, please make it your business to understand it, because if you're not going to hold them accountable, we don't think the plans are going to hold themselves accountable. And I never see anything from CMS or any of the other states essentially writing them on violation of utilization management standard that got them that accreditation and got them into the contract in the first place. Dr. Moore?
Yeah, I'll just say that I think it's usually going to be in your contract often if because it has requirements of both the hospital and of the plan and contracts. And often the contract, it will mention that, Plan X will maintain certification with, one of the accrediting bodies. If they do, that is a way in to and often they do, they have to be able to, provide Medicaid or Medicare Advantage or whatever, but that is a way into those standards as being a level set on performance. And, so like Brian was saying, I think it's a nuanced argument, but nonetheless, without having these governors on behavior, meaning your contractual governors, either that regulatory governors. So the regulations are generally going to be the deferring body on plan performance, but in the areas where they're not specific or they're not, plans can agree to more restrictive turnaround times on their performance if they're accredited by an organization that requires it. And so if they're not following those, I think using that as an additional reason that you have a dispute with them makes sense. And we should be pursuing these as we are interfacing with plans on when we think that they're not following reasonable procedures.
It can be a great lever. It really can. And so again, it's not just timing, but it's also the quality of the appeal process and of the adverse determination process that needs to be called out. It is a part of the utilization management standard under these two accreditation agencies. And so we always make sure that we go into a client to find out whether or not the plan is accredited or not. And so there is a list on both NCQA and URAC that lists which plans are accredited and which ones are not. So avail yourself of these two websites. They also have a complaint portal. So don't think twice about complaining to a standards agency about poor behavior. So long as you know what the standard is, you can identify the violation, it can be reported.
Okay, thank you. All right, let's quickly kind of move through how to submit. It's not a difficult process. And I don't know if we're going to have time for questions, but we will. We do have them all saved. I mean, they will save, after a recording. And so we'll do our best to get back to you, either Brian McGraw or myself, with answers to your questions sometime this week after this webinar. So here's the link to go to the comments page, or it's a long link, or you can just use your favorite search engine and put in Medicare program or request for information on Medicare, and you should be able to find it that way as well. If you are filing a document to an official document docket, please do not include any PHI because it will be publicly viewable. You can go in and look at the comments. CMS reviews them first and then publishes them on the website. This is what the website looks like. I have circled there up at the top, submit a formal comment. That's how you get started. You can also read, as of yesterday, there were 600 public comments, more today, I'm sure. And then down below is the whole request for information from CMS. The two areas that I talked about that would be our focus anyway is coverage and care, sections B10 and B11. And so these are the ones that talk about how MA plans are using utilization management techniques such as prior auth. What approaches are they using to exempt certain clinicians or items or services from prior auth? And so really it's not only about the provider protections, but it's also about our patient protections to make sure that patients are not being adversely affected in getting access to medically necessary care. And then B11 is asking about what data CMS could use to help align MA plans for prior auth and other utilization management techniques. So you can comment on as many things that you want to. You can talk about as many things, different things as you want to, but those are the two things that I would recommend you focus on as well. And if you look at our template, it actually has those two sections in the actual template. The template that we've uploaded to this presentation, which you could download directly from GoToWebinar. If you're having trouble downloading it, just email me, Denise, D-E-N-I-S-E, at AHDAM.org. So that's AHDAM.org. If you're having trouble downloading, it's just a structure. We're not telling you what to say. It's just a nice little structured letter to kind of get you started so that you don't feel overwhelmed by having to create something to be posted for comment. Consider writing or voice transcribing your thoughts and concerns before you attach to the comment section or before you write them down into your letter if you want to submit it as a formal letter. Use your active voice, words like, their behaviors being unfair, unjust, dangerous, unethical, morally bereft, whatever you're comfortable with. How would you describe it to a panel of CMS administrators? How would you describe it to Congress if you were there in person? Citing an example, and Dr. Moore kind of spoke about this a couple of times, specific patient encounters that you have in mind, maybe not the bizarro ones that, that just make you go, what are they thinking? But the things that you see day after day after day, no PHI. When you go to submit your comment, they're going to ask you what is the comment about, and you can select your healthcare provider, your hospital, your nurse, your physician, your other healthcare professional. They have a long list of drop-downs, so just pick the one that is the most appropriate for your position. Consider adding an example of egregious denial letter or other payer correspondence that supports your comment. I have reviewed some of the comments that are in there, and I have seen some folks have uploaded additional documents with their comments, kind of showing, some of the behavior. Again, make sure there's no PHI, no patient information, or hospital-specific information in there. And I believe our two Brians probably believe as well, your comments, they may carry more weight if you can provide specific examples. So not something that is word of mouth or anecdotal, but give some specific examples of what you have experienced. You can attach up to 20 files, up to 10 megabytes in size, and then these are the file types that are permitted. Your email address is not required, but if you put it in there, you can opt to receive email confirmation that they did get your submission with a tracking number. And so if you want to track that, I don't think it's a bad idea to put your email in there. They're not gonna share it with anyone. You can also, even if you're not going to comment, you can go to the site and you can click on you want to receive any updates to it. And they just send you an email every day that shows you, that says, here's the link to the website, and it tells you how many comments they've received. Now, out of the 600 and some comments that they received, I think they have like 200 and some posted so far, because they are reviewing them first before they post them. But you can go in and search, put in search words and look for what you're interested in as far as the comments. So in summary, create and submit your comments. The most important thing is just submit, and submit before August 31st. Use your active voice, use real scenarios, and download the template from this webinar, or you can email me if you want the template, if you're having trouble getting it downloaded. Okay, did you, either of our Brians, have anything you want to add to summarize?
I've only got a 30-second close, and that is that there were 250 advocates on this call, and I think that if everybody would consider taking that link and sharing it with 5 colleagues and forcing it out so we can mushroom this, the more comments, the better. And so let's use the power of persuasion. And the fact that you all do have a network of friends who have experienced this, do not be shy about sharing it with a patient who's experienced a really difficult time with Medicare Advantage. And please, let's get it all done. We've only got 9 days left.
And I'll just finish with tell the story. Tell the story of what you're experiencing, what your patients are experiencing. Healthcare could be better than this, and it needs some help with oversight and improvement. And I think the light of day will help to maybe let those that are, we've seen significant improvements lately in their clarifications and what they're trying to, they're listening. And the August 3rd memo is really helpful to know that they are listening.
Right. All right. Thanks, everyone, for attending. Thank you to Brian McGraw and Dr. Brian Moore. Love listening to you guys. You really have a passion for this and make things seem so clear with your explanations. So very much appreciate both of you being on today. If you have any additional questions, you can contact me or Brian McGraw. This is your opportunity to have your voice heard, so let's take advantage of that. All right.
Thank you, Denise.
Thank you. Thanks, everyone.